Hello, this is Kay Afji, and I am going to take a few minutes to discuss the upper respiratory disorders and the care of the patients who have upper respiratory disorders. The upper respiratory tract, as you see here on the picture, includes the nose, the sinuses, the mouth, the pharynx, and the larynx. And there's infections that can be caused by viruses or bacteria, and these can then result in much more serious infections and actually can develop into disorders of the lower respiratory system. Upper respiratory infection, often called the common cold, and rhinitis, which is often caused by allergies. It's inflammation of the sinuses. Are two of the more common disorders of the nose and sinuses. A major goal in the care of the common cold is to prevent secondary bacterial infections because of the congestion and the secretions that build up within the sinuses. Those can result in bacteria more easily growing because of the medium, the secretions that are sitting there. So our major goal is to keep, if the patient has a common cold, to keep it from developing into something more serious. A person with a cold is contagious for about 3 days after the symptoms first appear, and colds are spread by droplet infection. Now, the immune function in the elderly is more compromised, so they are more at risk for contracting colds or upper respiratory infections. So if you have patients who are elderly, they should be encouraged to stay away from people who have such infections. So they should kind of stay away from crowds during cold and flu season to prevent infections from occurring. If you work in a long-term care facility and you're developing upper respiratory infection, you may want to stay away from caring for those individuals because you would risk spreading your infection to your residents. If a cold develops in an older person, they're much more likely to develop a secondary infection. So if they do come down with a cold, it's really important to encourage them to increase their fluid intake, get lots of rest until the cold symptoms are completely cleared. Sinusitis is the inflammation of the mucosal lining of the sinuses. This can be caused from an infection that is spread from the nasal passages to the sinuses and blockage of normal sinus drainage routes. So if there's more buildup of sinus drainage, again, that's going to lead to inflammation of the mucosal lining of the sinuses. Sinusitis is often caused by pneumococci, streptococci, or Haemophilus influenzae. Deviated septum or nasal polyps can cause blockages of the nasal passages. Signs and symptoms of sinusitis would be headache, fever, malaise, tenderness over the sinuses, purulent drainage from the nose. Sometimes patients complain of a non-productive cough. The upper teeth may become painful due to the accumulation of exudate in the sinuses, which can cause pressure. To relieve the pain and promote sinus drainage and control infection, and then also to prevent reoccurrence, we encourage patients to use moist, hot packs over the sinus area. We can encourage them to inhale moist steam, which will thin secretions and help promote the drainage. And there are also kits available like neti pots that can be used to irrigate the sinuses. And these are available at drugstores, so they're available over the counter and patients don't need a prescription for them. And patients often say that that seems to help as well. If the cause of the sinusitis is a bacteria, then the infection can be treated with an anti-infective agent, often for at least 10 days to 2 weeks. Patients are encouraged to rest, to reduce stress, eat a balanced diet, and control allergens to decrease the occurrence of allergies. Analgesics can be given for pain. Usually it's a non-opioid analgesic that's given. Fluid intake again should be increased, and dairy products amounts should be lowered because dairy products have a tendency to increase the thickness of the secretions and make them much more difficult to remove. Commonly prescribed drugs for allergic rhinitis and sinusitis are antihistamines. Antihistamines can cause sedation or stimulation in the patients. We encourage patients to report any changes in heart rate because it can result in palpitations and also can result in urinary retention, so we want to watch for those side effects. Patients can be started on corticosteroid sprays for allergic rhinitis, which inhibits the inflammatory response and can be used daily as directed. Patients may also be started on mast cell stabilizers to prevent the inflammatory response from occurring before the patient is even exposed to any allergens. And then decongestants may also be prescribed, which decrease the edema in the nasal passages. However, decongestants are contraindicated for patients who have hypertension, glaucoma, or prostatic hypertrophy, as they can exacerbate problems with those conditions. If patients take decongestants, they can use 3 to 4 times per day, but for no longer than 3 weeks. I also wanted to mention that aspirin should not be given to a child under the age of 18, as aspirin is associated with the occurrence of Reye's syndrome in the pediatric population. Also, adults taking anticoagulants or nonsteroidal anti-inflammatory drugs should not take aspirin because aspirin will further prolong clotting time. So if a patient is complaining of discomfort due to sinusitis, again, we would not recommend that patients who are younger than 18 or patients who are on anticoagulants or nonsteroidal anti-inflammatory drugs take aspirin as a pain reliever. Okay, next we look at epistaxis. Epistaxis, otherwise known as nose bleeding. Causes of nosebleeds are decrease in humidity, so dry air, can be occurring as a result of allergies with inflammation. It can occur as a result of overuse of nasal spray or because of snorting of street drugs. Bleeding is the only sign you're going to see. Normally they're not complaining of pain or anything like that. It's usually the patient will come in with bleeding from the nose. Management of nosebleeds, if it's minimal bleeding, we have the patient sit forward and we apply direct pressure by pinching the soft portion of the nose and holding that pressure for about 10 to 15 minutes. Cold compresses can also be applied. If the patient sustains persistent bleeding, a small gauze may be inserted into the nostril, which would apply pressure. The patient needs to go to the emergency room if bleeding continues to cauterize the bleeding vessel. So if small gauze is inserted into the nostril and pressure is applied and the bleeding continues to be persistent, then the patient should be advised to go to the emergency room so that the physician can cauterize the bleeding vessel. Okay, other treatments, of course, rest should be encouraged. And as far as patient teaching goes, we teach the patient not to blow their nose or to pick their nose until at least 24 hours has passed after the bleeding has stopped. And here you see a picture of a healthcare provider applying pressure to the patient's nose to try and have it stopped. So we have the patient tilt their head slightly forward and we apply pressure to the soft tissue on the nose. Okay, the next condition we're going to look at is pharyngitis, which is an inflammation of the pharynx and is usually called a sore throat. Laryngitis occurs if the infection progresses down into the larynx. If the inflammation extends to the epiglottis, it's called epiglottitis, and this occurs most often in children. Pharyngitis is usually viral. Often the cause is, if it's bacterial, it's caused by a strep infection. Fungal pharyngitis will occur or can occur if the patient is on long-term antibiotics or inhaled corticosteroids, or if a patient is immunosuppressed. Then you'll see the patients developing a yeast infection of their pharynx and larynx, etc. The signs and symptoms: patients complain of a dry, scratchy feeling in the back of their throat. They may have a mild fever, complain of headache and malaise, and the throat, tonsils, palate, and uvula may be involved and will appear reddened. Dysphagia is also present with discomfort when swallowing one's own saliva. If the patient has laryngitis, the voice may become hoarse or absent. The usual course for uncomplicated pharyngitis or laryngitis is usually 3 to 10 days. A throat culture is often done to confirm or rule out strep infection. Treatment of nursing management of pharyngitis. For conservative measures, we encourage the patient to rest, drink plenty of fluids, and take a mild analgesic for pain. They also are encouraged to perform warm saline gargles, which involves a half a teaspoon to a full teaspoon of salt, table salt, to a glass of warm water. The patient then would rinse their mouth out, gargle with it, and then spit it out. Antiseptic sprays and lozenges are available over the counter to help provide relief from discomfort as well. Bacterial pharyngitis usually requires the administration of an antibiotic. We find that if a patient is complaining of strep throat and has a lot of discomfort, besides the warm gargling with salt water, we find that their pain pretty much decreases within 24 hours of that administration of the first dose of antibiotics. So usually it responds real quickly to that medication. Fungal pharyngitis is treated with an antifungal agent. So if they have a yeast infection, oftentimes they'll have a medication such as a nystatin oral solution or oral suspension, which the patient would then gargle with that solution 4 to 5 times a day. Again, and then just spit it out. And that's usually an effective treatment for a fungal infection. Okay, tonsillitis is an inflammation of the tonsils. The symptoms are usually the same as pharyngitis. Treatment again would be a throat culture would be done to assess the presence of strep. We're really concerned about strep infection because that can result in rheumatic fever or glomerular nephritis. Rheumatic fever being a heart problem, glomerular nephritis being a problem with the kidneys. If the infection is not treated promptly or completely, the infection then can travel to other areas of the body. Besides, if the tonsillitis is caused by an infection, antibiotics would be started. Also, warm saline throat gargles would be encouraged for discomfort besides the antibiotics, and bed rest, fever management by the use of an antipyretic medication such as Tylenol, and a liquid diet to decrease the irritation on the throat, but yet provide some nutrition to the patient. In some cases, surgery needs to be done to remove the tonsils when tonsillitis is recurrent or when the patient's airway is obstructed because of the large size of the tonsils. Preoperatively, the patients are NPO for 6 to 8 hours prior to the procedure. If the patient has a temperature or has any signs of an upper respiratory infection, they need to be reported to the surgeons so the surgery can be postponed, because we wouldn't want to be doing any type of surgery on a patient who has an active infection. Once the surgery is completed, postoperatively, the nurse would observe the patient for frequent swallowing. This could be a sign of a patient experiencing bleeding in the back of the throat from the area where the tonsils were removed, and they'll have frequent swallowing because they'll be swallowing some of the blood. Patients can also exhibit restlessness, which may also indicate bleeding in the throat. As far as management goes, citrus fruits, hot fluids, or rough foods should be avoided postoperatively. And the patient also should be discouraged from using straws, because we don't want that suction of sucking in a straw to cause any dislodgement of the scab that has occluded the bleeding where the tonsils were removed. Okay, so if we look at this question, which nursing interventions would be appropriate during the immediate postoperative period for a patient who has undergone a tonsillectomy? Select all that apply. Would we observe for frequent swallowing, monitor amount of drainage, position patients flat on their back, apply warm compresses, or provide humidified oxygen? So just take a minute to kind of think about what answers would be appropriate for someone who is just immediately post-op after having their tonsils removed. And the correct answer would be 1, observe for frequent swallowing, because that would be a sign of bleeding, and 5, providing humidified oxygen, because the humidified air will prevent the area from becoming dry and will promote healing. Monitoring for the amount of drainage, you're not be able to see that as the patient's going to be swallowing it. Putting the patient flat on his back may put him at risk for aspiration of any kind of bleeding that might occur. And applying warm compresses will only cause increased blood flow to that area and can exacerbate bleeding as well. Now let's look at another condition of the upper respiratory system, cancer of the larynx. Approximately 75 to 90% of all patients who are diagnosed early and treated with radiation and or surgery are cured of cancer of the larynx. There's a clear association between cigarette and cigar smoking and excessive use of alcohol and the development of laryngeal cancer. Lack of fruits and vegetables in the diet, gastroesophageal reflux disease, immunosuppression, and infection with the human papillomavirus or Helicobacter pylori or H. pylori also have been linked to an increased incidence of cancer of the larynx. There are quite a few risk factors. Exposure over long periods of time to environmental pollutants such as paint fumes and asbestos, coal dust also have been shown to be associated with increased risk. Signs and symptoms of cancer of the larynx. Patients are encouraged to seek medical attention if they experience signs of hoarseness lasting more than 3 weeks, a sore throat that lasts more than 2 weeks, consistent pain in or around the ear when swallowing, difficulty swallowing, a persistent dry cough for no apparent reason, blood in the phlegm or saliva lasting more than a few days, or any lumps or knots on the neck indicating an enlarged cervical lymph node. Early detection of cancer of the larynx is important because Once the cancer has spread beyond the vocal cords, it's much more difficult to treat. Diagnosis is established by visualizing the larynx with a laryngoscope, or also by doing a computed tomography or CAT scan of the larynx and the throat to identify any tumor. Treatment, once the type of cancer has been determined and staged, which means they identify if the cancer has spread beyond the larynx, then they determine treatment. Radiation alone is 85% effective in treating early cancers. Radiation can be combined with endoscopic laser choroidectomy for certain types of lesions as well. So besides radiation and laser, we can also offer that the patient have surgery performed, and the surgeon may decide whether to perform a partial or total laryngectomy. In a partial laryngectomy, the thyroid cartilage is split and only the tumor and involved portion of the larynx and vocal cords are removed. The patient at this point could still make some vocal sounds. A tracheostomy can be performed to facilitate breathing temporarily, but eventually that tracheostomy is closed and the patient can resume talking. A total laryngectomy is performed if the tumor has progressed to surrounding tissues and radiation therapy has failed. The surgeon excises the entire larynx, the epiglottis, the thyroid cartilage, the hyoid bone, the cricoid cartilage, and 2 or more rings of the trachea. If the tumor has extended to the lymph nodes, then a neck dissection is also performed. And with the neck dissection, all the muscles, lymph nodes, and soft tissue from the lower edge of the mandible to the clavicle and from the top of the trapezius muscle to the midline are removed. A permanent tracheostomy is then performed when that surgery is done. A laryngectomy tube, which is shorter and wider than a tracheostomy tube, is put in place before the patient goes home. And after the stoma is completely healed and matured, about 6 weeks after the surgery, the tube can be taken out as long as there's no compromised airway. So the patient would be able to breathe through that stoma that's created. The patient may have a thin feeding tube inserted during surgery so that they can receive appropriate nutrition for about 10 to 14 days. Initially, they will have only intravenous fluids, but will progress to regular tube feedings as the healing progresses. When the patient is discharged from the hospital, a home care nurse or clinic nurse and or occupational therapist will continue working with the patient as an outpatient, working with them on their eating skills and helping them to train them in eating and swallowing. Also, they will be working with the patient as far as communication goes. In this diagram, you see an example of an electronic artificial larynx. It's a battery-powered device that's applied to the skin of the esophagus and is used to simulate speech. Sounds are not necessarily voice-like, they're more electronic-like, but they are understandable and make it possible for the patient to communicate. Let's take a minute to just look more closely at the tracheostomy. We talked about it a little earlier in response to the surgical procedure when they do a laryngectomy. But let's look specifically to a tracheostomy. A tracheostomy is the surgical incision into the trachea for the purpose of inserting a tube for breathing. If the patient has a tracheostomy, there is no connection between the nose and the mouth and the lower respiratory system. Why are tracheostomies done? The purpose of a tracheostomy is to assist or control ventilation by mechanical means over a prolonged time. So if the patient needs a ventilator, a breathing machine to help them to breathe, then a tracheostomy is placed, and then that hose from the breathing machine is attached to that tracheostomy. And this is done, if the patient's going to be on a ventilator for a long period of time. Sometimes tracheostomies are done to facilitate suctioning secretions in the air passages if the patient's not able to cough. So they place a tracheostomy where they intubate the patient so they're able to much more easily access their lower respiratory tract when they want to suction. Tracheostomies are also done to prevent aspiration of oral and gastric secretions. So in the case of a patient who's unconscious, or if they're paralyzed, they may place tracheostomy to prevent aspiration of secretions. And a tracheostomy can also be placed to bypass a constricted or obstructed airway. For example, if there's a tumor located above the site of the tracheostomy can be placed so that the patient is still able to breathe. In this picture, you see examples of different tracheostomy tubes that can be used. Some allow the patient to actually speak. Others are used more as a temporary type of tracheostomy. Others are used for patients who are going to be having a tracheostomy more permanently. So the patient's spouse asks, what is the purpose of the tracheostomy? Which comments demonstrate nurses' knowledge regarding the procedure? And you can again select all that apply. 1, it facilitates suctioning of respiratory secretions. 2, it prevents the recurrence of respiratory arrest. 3, it prevents aspiration of oral secretions in unconscious patients. 4, it bypasses an obstructed upper airway. And 5, it is a temporary airway for face and neck injuries. And again, the answers for this would be 1, 3, 4, and 5. Okay, as far as nursing management of the tracheostomy, it requires specialized nursing care, especially in the case of a patient who's attached to a ventilator. Immediately post-operative, the nurse focuses on maintaining a patent airway and observing for hemorrhage from the tracheostomy site. During the first 24 hours, the patient is monitored for signs of respiratory distress. If the patient's not able to cough to remove mucus and other secretions, then suctioning is necessary. Because if the lumen's not kept open, the patient will suffocate. Again, suctioning in this case, as with any other time, is done using a sterile technique to prevent infections. We also make sure that any oxygen or anything like that is humidified as it's being administered. When you're suctioning the patient, again, remember that you don't apply suction when you're passing the catheter into the tracheostomy. And as you're withdrawing the catheter, you do not leave the suction catheter in for more than 10 seconds at a time with suction. Lungs should be assessed. Lung sounds should be assessed before suctioning and then afterward to verify that the procedure was successful in clearing the airways. Preventing infection is also an important nursing responsibility. Incision is open wound with a minimal dressing on it. So we make sure that tracheostomy care is done as a sterile procedure. Psychological support of the tracheostomy patient and the family also is very important. The patient has to learn to breathe in a different way and cannot speak or call out for help when they have a tracheostomy. Eventually, they may be able to use a tracheostomy appliance that allows them to verbalize. But until that time, like I say, psychological support is very important. A patient may be experiencing grief over the loss of their natural voice and also the inability to eat normally. The tracheostomy patient, of course, needs to, or laryngectomy patient needs to be taught how to swallow after partial laryngectomy is done. Communication is also important. They may have to communicate with writing. They may be able to use the electronic device as appropriate. The speech therapist may have to work with the patient regarding how they're going to communicate in the future. Also, referrals to support groups that are aimed at serving laryngectomy patients or tracheostomy patients may also be extremely helpful during the rehabilitation phase. Now, after completing the online lecture and the readings in your DWIT textbook, I would highly recommend that you go to the end of the chapter, chapter 13, and review the review questions for the NCLEX exam. They're specifically aimed at your readings, or most of them are application questions. And the answer key to these questions, as well as the rationale, is located in your Evolve resources for your DeWitt textbook.